Case 1. It presents a 45-year-old patient who's suffering from chronic worsening arthritis,
Right.
specifically in the lower back and hips, which, that already suggests a structural problem. But the biochemical clues are subtle, and they're visual. Their sclerae, the whites of the eyes, are described as having this bluish or brownish tinge.
Not quite white.
Not quite white. And here is the fact that, it just instantly gives away the diagnosis. Their urine, which is a normal color when it's first collected, turns dramatically dark, almost black upon standing.
Wow.
So what specific metabolic failure are we looking at here?
This is the absolute textbook presentation of alkaptonuria. Historically, it was often referred to as ochranosis.
Ochranosis, okay.
That darkening of the urine, particularly after it's been exposed to air for a little while, it's almost pathognomonic. It's the classic sign.
So the whole syndrome points to one enzyme.
The entire syndrome, the darkening, the joint pain, the blue-brown skin discoloration, it all points directly to the failure of a single enzyme, homogentisate oxidase.
Okay, so if that enzyme has failed, what's the consequence? What does homogentisate oxidase normally do, and why is its absence causing this systemic structural problem?
Well, homogentisate is a specific derivative that's found in the breakdown pathway of phenylalanine.
An essential amino acid.
The essential amino acid, which first converts to tyrosine. So this is a few steps down the line. Homogentisate is supposed to be converted into a compound called mallyl acetoacetate.
Right.
When that enzyme is deficient or just non-functional, homogentisate accumulates. It just builds up. And the reason this accumulation is so visually striking, the darkening of the urine, is because homogentisate is highly, highly prone to oxidation.
So the urine is fresh and it looks totally normal until the moment it mixes with atmospheric oxygen. And then the oxidation and polymerization begins. And that's basically the same process that's causing the internal damage, isn't it?
That's exactly it. Once it's exposed to oxygen, whether that's in the sample cup or, much more slowly inside the body's tissues, it oxidizes and polymerizes. And it creates this dark black pigment.
And this pigment just deposits everywhere.
It deposits throughout the body, but particularly in collagen-rich areas. So we can almost think of this process as, well, it's like rusting the patient's joints from the inside out.
Wow, that's a powerful image.
And that deposition in the cartilage and the connective tissues is what causes the ochranosis, so the discoloration of the sclerae and skin, and critically, the severe, debilitating, and chronic arthritis that was noted in the patient.
I remember from the sources that this accumulation defect, while it's causing all the structural damage, it's relatively benign when it comes to brain development, unlike some of the other amino acid defects we're going to talk about.
Right.
And this ties back to the metabolic classification of the molecule itself.
That's a really important point for comparison. Homogentisate is normally metabolized into both acetoacetate, which is ketogenic, and also fumarate, which feeds directly into the TCA cycle, or the Krebs cycle.
So it's both ketogenic and glucogenic.
Exactly. And because the defect happens so late in the overall phenylalanine pyrethine pathway, it's after the major steps that usually cause neurological issues, the defect primarily impacts mechanical structural health.
So joints and connective tissue integrity.
Right. Not cognitive development. The body has already processed the most toxic precursors up to that point. So the brain is largely spared.
And the treatment strategy reflects this, right? Since the damage is this mechanical accumulation, we'd focus on restricting the precursor, but the therapy is really geared toward treating the arthritis itself.
Correct. The core goal is symptom management. Of course, dietary restriction of tyrosine and phenylalanine helps reduce the overall incoming load of homogenisate production. But
the damage is done.
Exactly. Once the pigment deposition, the ochranosis, has occurred, it is incredibly difficult to reverse. So early diagnosis and lifelong restriction are absolutely crucial for minimizing future joint degradation. It really highlights the difference between this chronic mechanical failure and our next case, where prompt early intervention is, well, it's a matter of life and death.
And here's where the contrast really sharpens, because we immediately jump to case 15, the mouse odor malady, phenylketonuria, or PKU.
PKU.
The classic. We're talking about a 2-year-old boy with poor development, vomiting, irritability, and that really strange mousy or musty odor in his urine. And the lab confirmed it. A serum phenylalanine level of 28 milli-GDL. That's a massive elevation.
It's a huge number. And PKU is a profound and completely different presentation of a defect in the same overall amino acid pathway. Where alkaptonuria blocked a late downstream cleanup step, PKU blocks the crucial first step. the conversion of phenylalanine into tyrosine.
Okay, so a different enzyme.
A different enzyme, much further upstream. The defective enzyme here is phenylalanine hydroxylase.
So because that initial processing step is blocked, phenylalanine accumulates incredibly rapidly.
Sure.
And as it reaches these toxic levels, the body tries to get rid of it. It shunts it into these alternate pathways, creating the phenyl ketones that cause that distinct musty odor the source material points out.
Exactly. Phenylalanine is an essential amino acid, meaning we have to eat it to survive. But the moment that enzyme fails, that essential nutrient becomes a potent neurotoxin.
Especially in a developing brain.
Especially during the rapid development of the brain in infancy. PKU is inherited in an autosomal recessive fashion. And if you leave it untreated, the consequences are severe and often irreversible. Failure to thrive, severe developmental delay, microcephaly, and often chronic eczema. It is a true emergency of biochemistry.
This makes it the absolute poster child for public health success, doesn't it? We screen for it because we know the damage is permanent, but it's also preventable.
Completely preventable.
Now let me ask the challenging question here. If phenylalanine is essential for building proteins, how can we possibly treat PKU by restricting it? Doesn't the body still need phenylalanine to grow?
That is the core paradox of PKU treatment, and is why the management is so complex and so precise.
Okay.
The patient does need phenylalanine, but only in the absolute minimal quantity required for protein synthesis. They have to be on a carefully measured, restricted diet to keep the serum levels within a very safe, narrow therapeutic window.
High enough for growth.
But low enough to prevent neurotoxicity.
Yeah.
And they also need supplementary tyrosine, because they can no longer make it from phenylalanine. Tyrosine effectively becomes an essential amino acid for these patients.
The sources emphasize this really critical molecular nuance about the phenylalanine hydroxylase enzyme itself. It requires a cofactor, tetrahydrobiopterin, or BH4. Why is that specific detail so clinically important?
Because it expands the differential diagnosis. And it expands the treatment options beyond just simple dietary restriction.
How so?
If a patient presents with high phenylalanine levels, it is not always a mutation in the main enzyme itself. It could be a defect in the synthesis or the regeneration of BH4.
Ah, so it's a problem with the cofactor, not the enzyme.
Exactly. And why does this matter? Because BH4 is also a critical cofactor for enzymes involved in making major neurotransmitters, like serotonin and dopamine.
Oh, wow.
So if you miss that BH4 link and you only restrict the diet, you might control the phenylalanine levels, but the patient will still suffer profound neurological issues because of a lack of neurotransmitters.
So the treatment would be different.
Completely. In those cases, treatment involves supplementing BH4 directly. It's a totally different approach.
That's a truly fascinating level of molecular detail guiding clinical practice. And speaking of practice, you mentioned the mandatory newborn screening. How quickly does this typically happen, and what methods do they usually use?
The screening is crucial. It's typically mandated within just a couple of days of birth, often before the baby even leaves the hospital, because treatment has to begin immediately to prevent irreversible damage.
And the methods?
Historically, they use something called the Guthrie test, which is a simple bacterial inhibition assay. But today, it's primarily done using tandem mass spectrometry or high-performance liquid chromatography, HPLC, on a dried blood spot.
So much more advanced.
So much more. These techniques allow for rapid, simultaneous detection of dozens of metabolic disorders from a single sample, confirming that biochemistry is just. It's central to preventative health.
Okay, moving on to case 9. We transition to another amino acid mystery, but this one appears more structurally focused. Homocystinuria. We have a 12-year-old boy with developmental delay, vision problems characterized by bilateral dislocated lenses, what we call subluxation.
Subluxation, right.
And a body habitus that resembles Marfan syndrome. So tall, thin, with long limbs. Labs show elevated serum homocysteine and elevated methionine.
This is a devastating diagnosis, and it stems from reduced activity of the enzyme cystathionine synthase.
Okay.
This enzyme sits at a major metabolic crossroads. It's responsible for converting the potentially toxic homocysteine to cystathionine, and in doing so, it bridges the methionine pathway and the cysteine pathway. When it fails,
It all backs up.
the homocysteine backs up, and because that flow is blocked, its precursor, methionine, also accumulates. That's why you see both of them elevated.
The physical presentation, the marfanoid habitus, and the lens instability, that really suggests a connective tissue crisis. How does the accumulation of homocysteine cause that widespread structural damage?
High levels of homocysteine are extremely toxic to two major systems. First, they fundamentally damage the vascular endothelium, the inner lining of the blood vessels.
Which leads to clotting.
It dramatically increases the risk for major thrombotic and cardiovascular disease. So early coronary disease, stroke, peripheral artery disease. It's a huge risk factor. Second, the sources confirm that homocysteine interferes with and inhibits proper collagen cross-linking.
Ah, so it can't build properly.
Exactly. This failure to correctly assemble structural proteins is why we see these severe connective tissue defects like osteoporosis, the skeletal structure resembling Marfan syndrome, and of course the instability of the ocular lens.
And here we are again, back at the critical role of cofactors. This enzyme, cystathionine synthase, also requires a key vitamin.
That's right. It relies on vitamin B6 or pyridoxine. And for about half of the patients, simply supplementing with massive doses of B6 can act as a kind of pharmaceutical dose.
So it just boosts the remaining function.
It dramatically increases the residual enzyme activity enough to successfully manage the condition. And this is a massive win when it works. It effectively turns a genetic disorder into a treatable vitamin dependency.
But why does only half of the patient population respond to B6? I mean, if the cofactor is missing or needed, why wouldn't it help everyone?
It's because the underlying genetic defect varies from person to person. In the B6 responsive patients, the mutation might cause the enzyme to be, say, unstable. And adding all that excess B6 helps to stabilize it enough for it to function partially.
And the non-responders?
In the B6 non-responders, the mutation is likely much more severe. It might result in an enzyme that is structurally incapable of functioning at all, regardless of how much cofactor you throw at it.
So for the non-responders, it's back to strict dietary management.
Yes. For them, it requires a rigorous dietary intervention, restriction of a methionine, the upstream precursor and supplementation of cysteine, which, just like tyrosine and PKU, becomes an essential amino acid that the body can no longer synthesize efficiently because of the blockage.
You raised a point earlier about the differential diagnosis being crucial here. The specific lab profile tells us which defect we are treating.
Absolutely. The fact that the patient in case 9 had high homocysteine and homethionine pointed us directly to the cystathionine synthase defect. But if the patient had a defect in a different enzyme, say methionine synthase,
which does the reverse reaction.
Exactly. It's responsible for converting homocysteine back to methionine, a process that requires vitamin B12 and folate. If that was the defect, the lab picture would be different.
How so?
You would still have high homocysteine, which is the toxic molecule, but you would see low serum methionine because the product of that reaction can't be formed. That precise ratio of accumulating intermediates is the biochemical key to the diagnosis.
We're going to shift gears now. We're moving from the complex chronic damage of amino acid accumulation to the rapid systemic failure of energy production. This is a category that includes environmental toxicity and inherited metabolic crises.
A big shift.
And we start with case 2, an urgent toxicology detour, cyanide poisoning. A 36-year-old is rushed to the ER. They're unconscious, breathing rapidly, with skin described as bright red, and that classic, though often undetectable, bitter almond breath. This is an immediate, deadly disruption.
This is a chemical attack on the cellular power grid. Cyanide is a highly effective direct inhibitor of the electron transport chain, the ETC. Specifically, it targets the final step. It inhibits cytochrome oxidase or complex 4.
Okay, let's spend some time defining the mechanism here. How quickly does this halt energy production, and why? Why does it lead to that strange presentation of bright red skin?
Well, complex 4 is the terminal end of the ETC. Its job is to accept electrons from the chain and use them to reduce oxygen to water. It is also a critical proton pump.
Right.
By inhibiting it, you immediately halt the entire flow of electrons down the chain. This means all the upstream complexes stop. NADH and FADH2 just pile up, unused. And oxygen cannot be utilized, even though it's in the blood.
And that explains the skin color.
That's the bright red skin. It's a clinical manifestation of this internal cellular suffocation. The blood is still carrying oxygen, but since the mitochondria can't accept it, the blood doesn't dump its oxygen load into the tissues. This leaves the venous blood artificially high in oxygen concentration, making it look bright red.
And the true tragedy here is the immediate energy shutdown.
Yes, the failure of complex 4 prevents the pumping of protons, hydrogen ions, from the mitochondrial matrix into the inner membrane space.
So the gradient collapses.
The electrochemical potential energy, that proton gradient that's built up across the inner mitochondrial membrane, it weakens severely. And that gradient is the energy source required for ATP synthase, complex V, to function and make ATP. If the gradient collapses, ATP production stops almost instantly. cell function ceases, and the patient goes into catastrophic system failure.
I appreciate that the sources force us to distinguish between inhibitors and uncouplers because they both lead to low ATP, but they do it through different mechanisms.
That distinction is absolutely crucial for understanding how the mitochondrion works. Cyanide is a chain inhibitor. It blocks the flow, causing a molecular traffic jam. Other inhibitors are amidyl and rotenone, which hit complex I. By contrast, an uncoupling agent, like 2,4-dinitrophenol or DNP, doesn't stop electron flow or the proton pump.
DNP acts like a shortcut, right? A leak in the dam.
Precisely. DNP acts as a shuttle. It carries protons back across the inner membrane, effectively bypassing the ATP synthase turbine. The proton gradient still forms, but the energy stored in that gradient is immediately released as heat instead of being captured as ATP. This process, uncoupling oxidation from phosphorylation, can cause dangerously high body temperatures. And then you have the third category, an ATP synthase inhibitor like oligomycin, which physically locks the turbine itself. The proton pump runs, the gradient builds up, but ATP still isn't made because the enzyme is physically blocked.
These examples just show the precision with which we can isolate different parts of the energy machine.
They do.
So given this rapid ETC failure, the treatment must be equally rapid and ingenious.
The treatment strategy for cyanide is remarkably elegant. It relies on creating a competitive binding partner. We administer amyl nitrate.
Okay.
Amyl nitrate oxidizes the patient's hemoglobin into methemoglobin. Now, while normal hemoglobin carries oxygen, methemoglobin has a very high affinity for cyanide.
So it's the decoy.
It is a chemical decoy. By rapidly generating methemoglobin, we create something that strongly binds the circulating cyanide, effectively diverting it away from the critical cytochrome oxidase enzyme. This gives the ETC a chance to restart and reverse the cellular damage before vital organs fail.
Moving from rapid poisoning to an inherited chronic energy crisis. Case 16, pyruvate dehydrogenase, PDH, deficiency. This is a 6-month-old baby with profound lethargy, poor feeding, seizures, and the lab results show severe acidosis, low pH, elevated pyruvate, elevated alanine, and critically decreased citrate.
This is a classic presentation of a failure right at the gateway of aerobic respiration. The pyruvate dehydrogenase complex, or PDH, is the critical link between the production of fuel from sugar, glycolysis, which gives you pyruvate, and the main power generation cycle, the TCA cycle, which needs acetyl-CoA.
So PDH converts pyruvate to acetyl-CoA.
Exactly. Without PDH activity, that gateway is locked shut, and pyruvate accumulates massively.
And that accumulation is what sets off the dangerous biochemical cascade that leads to the clinical symptoms.
Absolutely. The excess pyruvate has to be metabolized, and the body shunts it primarily in two directions. First, it's converted into lactate via lactate dehydrogenase. This causes the severe lactic acidosis and the wide anion gap that you see.
And the second direction?
Second, it's shunted into alanine via alanine aminotransferase, which explains the elevated alanine levels. Furthermore, the TCA cycle starves. Citrate is formed by combining oxaloacetate and acetyl-CoA, so if you have insufficient acetyl-CoA, that leads directly to the observation of decreased citrate.
The sources highlight the severe neurological symptoms. Why is the brain so susceptible to a PDH deficiency compared to, say, muscle tissue?
The brain relies almost exclusively on continuous glucose metabolism to function. Glucose feeds pyruvate, which has to pass through the PDH complex to generate the necessary ATP.
Can't use other fuels easily.
Right. Unlike other tissues, the brain has a limited capacity to use fatty acids or other fuels as primary energy sources. So a PDH failure causes a profound catastrophic energy shortage, specifically in the CNS, which results in seizures and developmental failure very early in life.
The treatment for this metabolic blockage is fascinating. It's basically a metabolic bypass designed to circumvent the defective PDH step entirely.
It is an incredibly clever adaptation. The treatment involves a high-fat, low-carbohydrate ketogenic diet. The goal is to provide fuel that converts directly into acetyl-CoA, so you can feed the TCA cycle below the blockage.
So you just skip the broken step.
You skip it entirely.
Yeah.
Fatty acids break down into acetyl-CoA, and even more specifically, we focus on the only two purely ketogenic amino acids, leucine and lysine. These are critical components of the diet because they can also break down directly into acetyl-CoA without having to generate pyruvate first. They offer a direct high-octane fuel line to the TCA cycle.
That sets us up perfectly for case 18, which is another crucial deficiency in the energy cofactor system. Wernicke-Korsakoff syndrome, rooted in a deficiency of vitamin B1 thiamine. This is often seen in chronic alcoholism, but the mechanism is purely biochemical. A 36-year-old man presents with shortness of breath, palpitations, peripheral neuropathy, and edema.
This case illustrates the widespread systemic impact of one single missing cofactor. Thymine, in its active form thymine pyrophosphate, or TPP, isn't just necessary for one pathway. It is absolutely required for three crucial enzymes that are central to almost all energy production and sugar metabolism.
Don't just list them. Tell us the functional impact of losing all three of these TTP-dependent enzymes at the same time.
Okay, it's the cellular equivalent of losing the gateway, the main engine, and the alternative supply line all at once.
Wow.
The three TPP-dependent enzymes are, first, pyruvate dehydrogenase, PDH. That's the gateway linking glycolysis to the TCA cycle. Failure means pyruvate backs up, causing lactic acidosis.
Which we just discussed.
Exactly. Second, iketoglutarate dehydrogenase. This is an essential enzyme within the TCA cycle itself. Failure here dramatically slows the entire cycle, crippling overall ATP output.
And the third?
And third, transketolase. This enzyme is essential for the hexose monophosphate shunt, or the HMP shunt. This is the body's alternative sugar pathway, critical for generating precursors for nucleotide synthesis and, importantly, NADPH for antioxidant defenses. When thiamine is deficient, all three of these major metabolic engines just sputter, leading to the systemic chaos we see.
And the resulting systemic symptoms are so severe because the deficit hits so many places. We see the cardiovascular issues, wet beriberi, with congestive heart failure and edema, and then the neurological issues, dry beriberi, characterized by peripheral neuropathy.
And if the chronic deficiency continues, it leads to the classic central nervous system syndromes. The acute phase is Wernicke encephalopathy, marked by ophthalmoplegia, which is paralysis of eye movements, nystagmus, ataxia, and profound confusion.
And if that's not treated?
If treatment is delayed, this progresses to Korsakoff syndrome, which involves irreversible memory loss and confabulation. The anatomical clue, often visible on an MRI, is atrophy or degenerative changes, particularly in the mammillary bodies, which are highly metabolically active regions involved in memory formation.
Now let's move back to the storage of fuel and another crisis of sugar handling. Case 19 brings us to the liver and von Guericke disease, type I glycogen storage disease GSD. This is another critically ill baby, 6 months old, experiencing restlessness, sweating, and seizures post-feeding. Labs show marked fasting, hypoglycemia serum glucose of 20 mg/dL, severe lactic acidosis, and an immense anion gap.
This severe, life-threatening disease is caused by a deficiency of glucose-6-phosphatase. We can think of this enzyme as the liver's final gatekeeper or checkpoint.
What do you mean by that?
Its job is to remove the phosphate group from glucose-6-phosphate, which is the necessary step for free glucose to exit the hepatocyte and enter the bloodstream. This is the last step for releasing sugar derived from both glycogen breakdown, glycogenolysis, and making new glucose, which is gluconeogenesis.
So the liver is full of stored sugar, but it can't release it into the circulation. It's metabolically trapped.
Precisely. The liver accumulates glycogen, causing massive hepatomegaly, and it also accumulates the trapped intermediate, glucose-6-phosphate, or G6P. The failure to release free glucose is what causes the severe fasting hypoglycemia and the seizures.
And the G6P accumulation.
The accumulation of G6P forces it down the only open road, glycolytic pathway. The pathway gets overwhelmed, producing enormous amounts of pyruvate, which then rapidly shunts to lactate. And that results in the severe lactic acidosis and the wide anion gap.
And the complications don't stop there. This is a perfect example of a cascade effect.
It is. The chronic, sustained high lactate load inhibits the renal excretion of uric acid, which leads to severe hyperuricemia and potentially gout, even in infants and children. Furthermore, the excess sugar metabolites drive massive lipid synthesis, causing hyperlipidemia and sometimes the formation of xanthomas, which are fatty deposits in the skin. And long-term, there's a serious risk of developing liver adenomas that can occasionally undergo malignant transformation.
The treatment, then, is purely preventative, focused on maintaining a continuous slow glucose supply.
The treatment is all about preventing the fasting state, which is what triggers the catastrophic hypoglycemia. This is often achieved through continuous nocturnal feeding, maybe using a nasogastric tube overnight, or through the consumption of raw cornstarch.
Raw cornstarch.
Yes, raw cornstarch is a complex carbohydrate that's only slowly digested and absorbed in the intestine. It provides a steady, gentle stream of glucose into the blood for hours, preventing those dangerous dips. Additionally, a drug called allopurinol is used to treat the secondary hyperuricemia and prevent gout.
In stark contrast to von Guericke's massive liver sugar problem, let's look at the muscle side of glycogen storage. Case 14, McArdle disease, type VGSD. A 19-year-old college student complains of extreme muscle aches, dark Coca-Cola-colored urine after exercising, and extremely high creatine kinase levels.
McArdle disease is caused by a specific deficiency of muscle glycogen phosphorylase. Unlike the liver's version of the enzyme, the muscle enzyme is specialized for one thing: breaking down the muscle's own stored glycogen into glucose 1-phosphate to be used as immediate fuel during anaerobic exercise.
So in McArdle disease, the muscle has its fuel tank full. It has the glycogen, but the key to the gas cap is missing.
That is a perfect analogy. The inability to access that local fuel is what causes the profound cramping, and the high creatine kinase in dark urine confirm muscle breakdown rhabdomyolysis. But the most critical lab clue is found after an exercise test.
And what's that?
It's the definitive biochemical signature. After an exercise tolerance test, the patient's blood lactic acid levels do not increase normally.
That is completely counterintuitive. If they are cramping and suffering muscle failure, shouldn't they be producing more lactic acid?
This is the genius of the diagnostic test. Lactic acid is the endpoint of anaerobic glycolysis, the metabolism of glucose derived from glycogen. If the muscle cannot break down its stored glycogen, it cannot feed the glycolytic pathway.
So it can't make lactate.
It cannot produce the necessary pyruvate to convert to lactate. The lack of lactate production, despite muscle failure, confirms the glycogen phosphorylase defect.
And what about the often reported second wind phenomenon that patients experience?
That's the body adapting by shifting fuel sources. After a brief period of severe cramping and rest, the local blood flow increases dramatically. This allows the muscle to start utilizing external fuels, namely free glucose and fatty acids, delivered via the bloodstream,
Bypassing the local storage problem?
bypassing the need for local glycogen entirely. The symptoms resolve as the systemic fuel takes over. And the treatment capitalizes on this. Patients are instructed to ingest simple sugars like sucrose immediately before anticipated exercise to prime the bloodstream with an alternate fuel source, and it significantly improves their exercise tolerance.
Okay, we're transitioning now into how the body handles major circulating fuels. Let's look at case 4, the cholesterol crisis of familial hypercholesterolemia, or FH. We're looking at a 27-year-old male with severe, shockingly early atherosclerosis, coronary artery disease, and those classic raised yellow-brown lesions xanthomas on the extensor surfaces.
FH is a major inherited disorder, and it's typically autosomal dominant. The severity is just staggering, especially in homozygotes who can have cholesterol levels up to 1,000 milli-GDL and frequently suffer fatal cardiovascular disease before they're even 30 years old.
And heterozygotes.
Even heterozygotes, who are much more common, have chronic severe elevations in LDL cholesterol.
What is the single molecular basis for this profound and unrelenting lipid elevation?
It's a defect in the LDL receptor gene. LDL receptors normally reside on the surface of hepatocytes, the liver cells, and they're responsible for binding and clearing LDL, the bad cholesterol, from the circulating blood.
So if the receptors are broken?
If the receptors are defective or absent, LDL just circulates endlessly. This leads to dramatically elevated plasma levels and the rapid accumulation of plaque in the arteries.
The xanthomas we see are basically the skin's effort to deal with this cholesterol overload.
That's right. If you look at those lesions under a microscope, they're composed largely of lipid-laden macrophages, often called foam cells. They're immune cells that are trying and failing to clear the excessive circulating cholesterol from the tissues. They're the visible sign of the molecular failure.
The pharmaceutical treatment here, statins, is incredibly effective, but I want to challenge the mechanism. The problem is failed clearance because of the lack of functional LDL receptors. Statins inhibit synthesis by targeting HMG-CoA reductase. How does inhibiting synthesis fix a clearance problem?
That is the beautiful paradox of statins, and is why they work so well. Statins target HMG-CoA reductase, which is the enzyme that catalyzes the rate-determining step in the liver's internal cholesterol synthesis pathway.
Okay.
By inhibiting this enzyme, we force the liver to reduce its endogenous production of cholesterol. When the liver senses this internal drop in cholesterol, it tries to compensate.
How?
It tries to compensate by increasing the number of LDL receptors on its surface to pull more cholesterol from the blood. So even if the patient only has a few functional receptors, statins force the upregulation of those receptors, enhancing the remaining clearance capability and ultimately lowering plasma LDL.
That is clever. It explains why the therapy works so well, leveraging the body's own compensatory mechanisms. Now let's look at a seemingly simple sugar causing a catastrophic systemic failure: Case 8, fructose intolerance. A 5-month-old infant who is fine while breastfeeding begins vomiting and sweating profusely after complementary feeding is introduced and develops severe hypoglycemia.
This is hereditary fructose intolerance. And the clue that the baby was fine on breast milk is absolutely essential. Breast milk carbohydrates are largely lactose, which is glucose and galactose, not fructose.
So the problem starts with the first taste of fruit or sugar.
The ingestion of any fructose, sucrose, or sorbitol triggers the problem.
And the enzyme failure is aldolase B. What happens when that enzyme fails?
Aldolase B is supposed to process fructose-1-phosphate into usable sugars. When it's deficient, fructose-1-phosphate accumulates in the liver cells. And here is the critical counterintuitive biochemical detail.
Okay.
The accumulation of fructose-1-phosphate sequesters, or traps, the free inorganic phosphate pi inside the cell.
Give us the metaphor for that trapping mechanism. How does trapping phosphate cause hypoglycemia?
Think of phosphate as the currency, the cash needed to run all the major metabolic transactions. Fructose-1-phosphate is like a molecular bank robber that ties up all the available cash in one non-transferable bundle.
So the cell goes broke.
The cell goes broke. Without free inorganic phosphate, the liver effectively halts all ATP production because you need pi to make ATP. This energy crisis immediately shuts down both gluconeogenesis making new glucose and glycogenolysis releasing stored glucose.
And if the liver can't do either of those?
If the liver can't make new glucose or release stored glucose, the patient plummets into severe hypoglycemia, causing the vomiting and the sweating. A single trapped intermediate indirectly kills the entire energy system.
And since the accumulated fructose-1-phosphate is toxic to the liver over time, the only treatment is absolute avoidance.
Strict, lifelong avoidance of fructose, sucrose, which is glucose plus fructose, and sorbitol, which converts to fructose, and the diet is necessary to prevent liver damage and these metabolic crises. It's a powerful lesson in how specific dietary components can be uniquely poisonous to specific genetic makeups.
We're going to transition now into problems of cellular cleanup and trafficking, the cell's recycling and post office systems. We begin with the devastating neurodegenerative disorder Tay-Sachs disease, which is case 17.
A tough one.
We see a 5-month-old girl of Ashkenazi Jewish descent who is developing normally but now is showing developmental regression, lethargy, an exaggerated startle reflex, and the pathognomonic finding, a cherry red spot in the macula.
Tay-Sachs is a sphingolipidosis, which is a type of lysosomal storage disorder. The enzyme defect is a deficiency of hexosaminidase A.
And its function.
This enzyme's function is to degrade the GM2 ganglioside lipid. Without hexosaminidase A, the GM2 ganglioside accumulates relentlessly in the neurons of the central nervous system.
The neuronal accumulation leads to the neurodegeneration, the developmental regression, and ultimately death. But that cherry red spot is such a strong visual clue. What exactly is it?
The macula itself is transparent, but the surrounding retinal cells are accumulating the undigested GM2 ganglioside. The contrast between the translucent macula and the opaque, swollen, lipid-filled tissue around it is what creates that striking cherry red appearance when you view it through an ophthalmoscope.
It's an autosomal recessive disorder, and tragically, the progressive neurodegeneration means children rarely survive past age 3.
That's right.
We have to pause here to discuss the differential diagnosis, because the cherry red spot is shared by another major lysosomal disorder.
The sources remind us that Niemann-Pick disease, another sphingolipidosis, also presents with a cherry red spot in about half of all cases.
And it's a different disease.
Completely different. Niemann-Pick involves a deficiency in sphingomyelines, leading to the accumulation of sphingomyelin. And clinically, it typically presents with dramatic hepatosplenomegaly, an enlarged liver and spleen and characteristic foam cells, which are macrophages containing lipid deposits with an onion-like appearance in the lysosomes.
And Tay-Sachs doesn't have that.
Conversely, Tay-Sachs does not typically involve the spleen or liver. We also have Gaucher disease, which is caused by a glucocerebrosidase deficiency. It's also highly prevalent among Ashkenazi Jews and involves massive splenomegaly. These distinctions underscore the absolute necessity of genetic screening in high-risk populations.
Our next lysosomal storage disorder, case 10, is Hurler syndrome, MPSI. We have a 1-year-old boy who presents with coarse facial features, severe skeletal abnormalities, hernias, stiff joints, and corneal clouding.
Hurler syndrome stems from a deficiency of IL-A-duronidase. This enzyme is essential for degrading specific glycosaminoglycans, or GAGs, these long, complex carbohydrate chains.
Okay.
Specifically, dermatan sulfate and heparin sulfate. Because the GAGs aren't degraded, they accumulate in the lysosomes of multiple tissues, and that leads to the coarse facies, the skeletal issues, and the visible sign of corneal clouding.
And there's a key comparator disease here, Hunter syndrome, which shows us how small differences in enzyme function translate to clinical presentation.
Hunter syndrome is MPS II. It's similar, but crucially it is X-linked, whereas Hurler is autosomal recessive.
And clinically?
Clinically, Hunter syndrome typically does not involve corneal clouding, and patients may sometimes exhibit aggressive behavioral issues, which offers a clear clinical distinction despite the similar underlying mechanism of GAG accumulation.
Now, let's use the complexity of treating Hurler to set up the next case. You mentioned that these lysosomal enzymes have to have an address label to get where they need to go.
That's the key to understanding the next two cases. Lysosomal enzymes are synthesized in the endoplasmic reticulum, and then they're refined in the Golgi apparatus. To be correctly delivered to the lysosome, they must be covalently linked with a specific tag called mannose 6-phosphate, or M6P.
Okay.
This M6P tag is recognized by M6 key receptors in the trans-Golgi network, and that ensures they are shipped internally to the lysosome. You can think of M6P as the UPS label that specifically says, deliver to lysosome.
That M6P tagging system fails entirely in case 11, eye cell disease or inclusion cell disease. This 2-year-old patient has features similar to Hurler, like mental retardation, stiff joints, and clouded corneas. But the lab test shows a baffling finding: elevated lysosomal enzymes in the serum.
This is the ultimate protein trafficking failure. The fundamental molecular defect is a mutation involving the Golgi apparatus, where the cell fails to add the M6P address tag to its lysosomal proteins.
So the enzymes are made correctly?
They're made correctly, but since they don't have the deliver to lysosome tag, the cell assumes they are intended for secretion and sends them out of the cell.
And that's why they're in the blood.
That's why you get high levels of lysosomal enzymes floating around in the serum.
But the material inside the cells still needs to be cleaned up.
Exactly. The lysosomes are effectively empty, and they accumulate these huge vacuoles, the inclusions, that are filled with undegradable material. This illustrates that having the correct DNA for an enzyme isn't enough. The cellular machinery must also correctly transport and sort the molecules.
This connects directly to the larger machinery of intracellular transport, doesn't it? The Golgi itself relies on specific proteins to maintain the flow of vesicles.
It does. The Golgi communicates heavily with the endoplasmic reticulum. The entire system of vesicle movement relies on coding proteins. COP-E proteins mediate anterograde transport moving vesicles forward, from the ER to the Golgi, and COP-I proteins mediate retrograde transport moving vesicles back from the Golgi to the ER, maybe to retrieve proteins that were sent by accident.
I see.
The eye cell failure, a defect in the M6P recognition system, shows that even when the major scaffolding, the COP-I and COP2 system, is working, a failure in the final destination tagging system can be catastrophic.
Shifting our focus from enzymatic storage to mechanical movement, we have case 12, Gardiner syndrome, which involves a failure in cellular motility. We see a 35-year-old infertile male with a history of recurrent sinus infections, a chronic cough, and surprisingly, cetus inversus his organs are reversed from their normal position.
Gardiner syndrome is a type of primary ciliary dyskinesia, and all three of those defining symptoms trace back to a defect in a single molecular motor. Dynin. Dynin is an ATPase motor protein that is essential for the movement of microtubules, which form the core structure of cilia and flagella.
So if the dynin motors are defective, the system fails in 3 distinct ways, depending on where those defective cilia are located.
Precisely. First, the sperm flagella rely on dynin for motility. Defective dynin leads to immotile sperm and therefore male infertility. Second, the cilia lining the respiratory epithelium are supposed to move mucus and trap bacteria up and out of the lungs.
But they can't.
If they're immotile, the patient suffers from chronic recurrent sinopulmonary infections, like chronic sinusitis.
And the third failure, the reversed organs, is just an embryological marvel.
It is a stunning realization of molecular control over macroanatomy. Early in embryonic development, the body requires nodal cilia to create a directional fluid flow that determines the left-right asymmetry of the organs. If these nodal cilia are immotile because of the dynin defect, the placement of the organs becomes randomized.
So it's a coin flip.
It's essentially a 50-50 chance, frequently resulting in situs inversus, where the heart is on the right side of the thorax. The appearance of situs inversus on a chest X-ray instantly confirms this diagnosis.
And we use the understanding of these molecular motors and targeted pharmacology.
We do. Microtubules are essential for cell division and movement. Antifungal and antiparasitic drugs like mebendazole and griseofulvin inhibit microtubule function in the pathogen. More critically, chemotherapeutic agents like vincristine, vinblastine, and Taxols are used in cancer treatment, specifically to interfere with microtubule formation or disassembly, thereby preventing the rapid division of cancerous cells.
Our final case in this section, case 13, is Lesch-Nyhan syndrome, a devastating purine pathway defect. We have a 2-year-old boy with irritability, severe, compulsive, self-mutilating behavior, biting his fingers and scratching his face, and the physical clue of orange-colored sand or uric acid crystals in his diaper.
This is a devastating X-linked disorder defined by a deficiency in the enzyme hypoxanthine guanine phosphorybosyltransferase, or HGPRT. And HGPRT is central to the purine salvage pathway.
Let's elaborate on the salvage pathway. Why is it so crucial for the cell?
Purines, the building blocks of DNA and RNA like guanine and hypoxanthine, are metabolically expensive for the cell to build from scratch. The salvage pathway is a critical metabolic efficiency route.
It's recycling.
HGPRT recycles hypoxanthine and guanine back into inosinic acid, IMP, and guanilic acid, GMP, for reuse. When HGPRT fails, the body cannot recycle these purines, so they are forced instead into the degradation pathway.
And the end product of purine degradation is uric acid,
leading to a massive overproduction and accumulation of uric acid. This causes severe hyperuricemia, acute gout, renal failure, and the visible manifestation of the uric acid crystals, the orange sand.
But the defining feature is the behavior.
What defines this syndrome and makes it so terrifying is the severe, compulsive, and inexplicable self-mutilating behavior, which is linked to profound purine and neurotransmitter imbalances in the central nervous system.
The treatment, then, is focused not on fixing the non-existent HGPRT, but on managing the toxic end product uric acid.
The treatment is allopurinol. This drug is a potent inhibitor of xanthine oxidase, which is the enzyme responsible for the final steps of converting hypoxanthine and xanthine into the less soluble uric acid.
Why is inhibiting the final step better than just trying to restrict purines in the diet?
Allopurinol is superior because it replaces a difficult-to-excrete waste product with 2 soluble, easier-to-excrete waste products. By inhibiting xanthine oxidase, the body instead accumulates the intermediates, hypoxanthine and xanthine,
which are easier for the kidneys to handle.
Crucially, hypoxanthine and xanthine are significantly more soluble than uric acid, and thus are more easily excreted through the kidneys. This prevents the devastating crystal deposits that lead to kidney stones and gout, although it must be said it does not address the neurological symptoms.
We're going to conclude our deep dive by looking at 3 major syndromes, starting with case 5, Down syndrome, or trisomy 21. We see a 2-day-old infant with typical physical features like upslanting palpebral fissures, macroglossia, and thick skin at the nape of the neck, and critical abnormalities like a confirmed heart defect.
Down syndrome is caused by trisomy 21, which is the result of non-disjunction of chromosome 21 during meiosis. This is the most common cytogenetic abnormality, and the risk increases significantly with advanced maternal age due to age-related failure of meiotic checkpoints.
The sources list an extensive range of associated abnormalities that accompany the cognitive impairment, particularly cardiac defects.
They do. In the GI tract, common issues include duodenal atresia, which is a block in the duodenum, duodenal stenosis, and annular pancreas. Physical features often include a single palmar crease, a short neck, and brush field spots, these small pale yellow spots on the iris.
And the heart defects.
Cardiac defects are especially common and are often complex. They frequently involve defects of the endocardial cushion, which separates the chambers of the heart, and that leads to atrial and ventricular septal defects.
We have several established prenatal screening and diagnostic tools for this condition.
Yes, prenatal screening markers in maternal blood include reduced levels of alpha-fetoprotein, or AFP, and elevated levels of beta-HCG. Ultrasound measurement of nuchal translucency, the fluid accumulation at the back of the baby's neck, is also used.
But for a definitive diagnosis?
A definitive diagnosis requires a karyotype analysis, often via amniocentesis, to confirm the presence of that extra chromosome 21.
And what are the unique long-term molecular risks that trisomy 21 patients face later in life?
This is a direct molecular consequence of the trisomy. Older individuals with trisomy 21 have a significantly higher risk of developing early-onset Alzheimer's disease.
Why is that?
It's because the gene encoding the amyloid beta precursor protein, which is implicated in Alzheimer's pathogenesis, is located on chromosome 21. Having 3 copies of that gene accelerates the production of amyloid beta plaque. They also have an increased lifetime risk for various leukemias, such as acute lymphoblastic leukemia.
Moving to case 3, DeGeorge syndrome. A 6-month-old with recurrent infections, muscle stiffness, carpopedal spasm, and a positive Schwalfsteck sign, a facial spasm upon tapping the facial nerve.
DeGeorge syndrome, often simply referred to as 22q11 syndrome, is a developmental failure that arises from improper development of the third and fourth pharyngeal pouches during embryogenesis.
This sounds like a structural failure that causes 2 distinct biochemical crises.
It is a double crisis. Those pouches give rise to the parathyroid glands and the thymus. First, aplasia or hypoplasia of the parathyroid glands leads to low parathyroid hormone, which results in severe hypocalcemia or low calcium.
And that causes the spasms.
Exactly. This causes neurological excitability, manifesting as tetany, muscle stiffness, carpopedal spasm, and that positive Schwalfsteck sign.
And the second crisis is the immune system failure.
Yes. An aplastic or underdeveloped thymus means the patient has a severe deficiency of functional T cells, which are the main regulators of cellular immunity. This leads to severe combined immunodeficiency and high susceptibility to viral and fungal infections.
The acronym CTCH22 is often used to summarize the common presentation of the 22q11 deletion.
That mnemonic is helpful for remembering the widespread effects.
Yeah.
C for cardiac abnormalities, A for abnormal facies, T for thymic hypoplasia, C for cleft palate, and H for hypocalcemia.
Right.
Furthermore, because of the thymic aplasia, a chest X-ray will typically show a reduced or entirely absent thymic shadow, serving as a critical diagnostic clue.
Our final case, case 7, is the most common inherited cause of mental retardation, Fragile X syndrome. A 6-year-old boy with developmental delay, large ears, flat feet, and speech delay, where genetic analysis shows an abnormal expansion on the X chromosome.
Fragile X syndrome is rooted in a fascinating molecular defect, an expansion of a massive CGG trinucleotide repeat sequence in the 5' region of the FMR1 gene on the X chromosome.
This isn't just a mutation, it's a dynamic amplification of a sequence. What does that expansion cause?
The immense expansion of that CGG repeat triggers a process called hypermethylation, the addition of methyl groups to the surrounding DNA. This hypermethylation effectively silences the FMR1 gene, inhibiting its transcription and preventing the production of the FMR1 protein.
And that protein is critical for brain development.
It's an RNA-binding protein that's critical for normal synapse maturation and neural development. Without it, the brain cannot form connections correctly.
Since it's X-linked, males are more commonly and severely affected, but it also exhibits that unusual pattern of worsening over generations.
It does. It demonstrates anticipation, meaning the severity of the disease tends to increase, and the onset occurs earlier in succeeding generations. This is because the number of CGG repeats tends to grow or expand when passed on from parent to child.
What are the key physical features beyond the cognitive and developmental delays?
Beyond the general delay, we see specific cranial and facial features. A long, narrow face, large jaw, large ears, and a prominent forehead. And post-pubertally, one of the most noted defining signs is macroorchidism, or abnormally large tests.
And this disorder connects to an entire class of neurological conditions based on the same mechanism.
Trinucleotide repeat expansion disorders represent a unique genetic class where sequences literally destabilize and grow. Besides Fragile X with its CGG repeat, we see Huntington disease, which is a CAG expansion on chromosome 4, myotonic dystrophy, and Friedreich ataxia. And across all these disorders, the general rule holds. Higher numbers of repeats are strongly correlated with a more severe phenotype and an earlier age of disease onset. The instability of the DNA sequence itself dictates the severity and the fate of the patient.
We have just covered 19 complex deep dives into the cellular machinery. We moved from environmental toxins that can halt the entire ETC in seconds, like cyanide, to subtle, decades-long genetic defects like familial hypercholesterolemia, and total systemic crises like PKU and von Gierke. The sheer volume of connections it's staggering.
It really is. And what stands out when you synthesize these cases is the absolute logical structure of biochemistry. Every complex, multi-system illness we discussed is fundamentally defined by the failure of just one critical enzyme.
Just one.
Whether it's HGPRT leading to self-mutilation in Leishnahan, or aldolase B trapping phosphate and fructose intolerance, or hexasaminidase A causing lipid buildup in Tay-Sachs. Understanding that one specific blockage transforms a frightening list of seemingly random symptoms into a logical biochemical puzzle. It clarifies why the patient has gout and seizures and a mouse odor all at the same time.
It also highlights the monumental success of modern public health, particularly the power of newborn screening for conditions like PKU, where knowing the metabolic pathway allows us to entirely prevent severe brain damage with a simple diet change.
And the critical role of simple cofactors and nutrients cannot be overstated. We saw how easily the energy systems are crippled when vitamin B1, thiamine, or vitamin B6, pyridoxine, is missing. Often, therapy isn't about fixing the gene, it's about optimizing the environment for the remaining enzyme activity.
Or finding a bypass.
Or finding a creative bypass, like using ketogenic amino acids, leucine and lysine, to sidestep a blocked pyruvate dehydrogenase pathway. It's chemical engineering applying to the human body.
We've also seen that cellular function is entirely dependent on precise transport and storage systems, whether it's the M6P tag ensuring enzymes reach the lysosome in Hurler and ICEL, or the dynein motor protein moving cilia in Cardiganer. The cell's post office and its construction crew are just as important as its power plant.
And that leads to a final thought for you, the learner. We've seen the catastrophic systemic consequences of misplacing one enzyme or allowing one metabolic intermediate to accumulate. If these highly specific molecules could speak, what would they tell us about the fundamental cost of just a small, persistent inefficiency?
That's a great question.
The deeper you dive into these biochemical pathways, the more you realize every physical trait, every neurological symptom, every vulnerability is simply a consequence of a molecule following its path or failing to do so. How much of everyday human variation and subtle dysfunction traces back to these small, elegant enzymatic inefficiencies? That level of molecular precision is the ultimate defining factor of human health.